Hey everyone, welcome to today's explainer. Today, we are going to completely master the neuroanatomy of the skull base together. We're doing a totally comprehensive, point-by-point breakdown of the jugular foramen. Seriously, we're covering every single anatomical landmark and all those fascinating eponymous clinical syndromes that pop up here, so you literally won't even need to open your textbooks after this. Let's get right into it.
Okay, let's dive into this. Here is our architectural floor plan for today's explainer. We'll start with the anatomy of the jugular foramen, then compartmentalization models, cranial nerve dysfunctions, Wernicke and Collette-Sicard, Villiet and Tapia, and wrap up with Jackson and Schmidt syndromes.
Section 1, Anatomy of the Jugular Foramen. Think of this as mapping out the physical hallway of the skull before we actually meet the tenants living inside.
So physically, the jugular foramen is one of a pair of openings tucked perfectly right between the lateral part of the occipital bone and the petrous part of the temporal bone. Now here's an interesting little quirk of human anatomy. The right jugular foramen is actually usually larger than the left. Inside, this space is divided by a spine coming off the petrous temporal bone, and it attaches via a fibrous bridge. But get this, in about 26% of cases, that bridge is actually ossified into solid bone. Moving outward, you've got the carotid ridge, which neatly separates our foramen from the carotid canal next door. And speaking of the neighborhood, we have cranial nerve 12, the hypoglossal nerve, passing right nearby in the hypoglossal canal, while the sympathetic nerves are busy wrapping around the carotid. Keep those neighbors in mind because they are going to become very important later on.
Moving right along to Section 2, Compartmentalization Models. You know, anatomists have famously debated for decades on exactly how to divide up this crowded little space.
We are essentially looking at two distinct historical classifications that map the exact same area differently. We've got the classic two-compartment model from 1967 by Hovelach, and then the updated three-compartment model from 1997 by Katsuda. Let's break these down point by point. Okay, starting with the 1967 model. This one used that bony spine and fibrous septum we just talked about to split the space into two rooms. First up is the pars vascularis. This is the much larger posterolateral compartment. Its tenants are the vagus nerve, its branching Arnold's nerve, the spinal accessory nerve, and the internal jugular vein. Then, the second room is the pars nervosa. This is the smaller anterior medial compartment. It houses the glossopharyngeal nerve, its branching Jacobson's nerve, the inferior petrosal sinus, and the meningeal branch of the ascending pharyngeal artery. Every single one of these tenants is packed so tightly into this dual-room layout. But then, the 1997 publication updated this view into three specific compartments. And honestly, this model is a total game changer for understanding neural syndromes because it completely isolates the nerves into their own dedicated space. First, you have the sigmoid compartment. That's the large posterolateral area containing the sigmoid sinus. Second, the petrosal compartment, the smaller anteromedial area holding the inferior petrosal sinus. And finally, sitting perfectly between them is the intrajugular or neural compartment. This right here is the dedicated central VIP lounge for cranial nerves 9, 10, and 11.
Section 3, Cranial Nerve Dysfunctions. Now, before we start throwing around all those complex eponymous syndrome names, we absolutely have to define exactly what happens when each specific nerve fails. So the crucial point is grasping these isolated building blocks. If you understand these individual failures, the syndromes literally just become simple math. Let's map them out so you don't miss a thing. A lesion to cranial nerve 9 results in the loss of taste and sensation in the posterior 1/3 of the tongue. Damage to cranial nerve 10, that causes paralysis of the vocal cords and palate, along with anesthesia of the pharynx and larynx. If cranial nerve 11 is compromised, you're going to see weakness in the trapezius and sternocleidomastoid muscles. A lesion to cranial nerve 12 results in tongue paralysis and atrophy. And finally, if the sympathetics are hit, the patient develops Horner syndrome. Memorize those, and you've got the keys to the kingdom.
All right, Section 4, Wernicke and Collette-Sicard syndromes. We are now looking at what happens during specific cluster evictions in our anatomical hallway.
And this brilliantly illustrates exactly how these clusters form. Take a moment to really absorb this stylized, watercolor-themed map of the neural pathways before we break them down textually. You can trace how a single lesion at the skull base intersects multiple pathways all at once. Notice how Wernicke sits tightly at the top near the foramen, while syndromes like Collette-Sicard drop further down to snag nerve 12.
Let's start with Wernicke syndrome. This one is strictly defined as a classic triad, a combined palsy of cranial nerves 9, 10, and 11.
Usually, this stems from an intracranial lesion, and because it perfectly encompasses those three specific nerves exiting the jugular foramen, it's classically known just as the syndrome of the jugular foramen.
Let's look at the etiologies for Vernet's syndrome, point by point, so we don't skip anything important. These include jugular foramen tumors, internal carotid artery dissections, mycotic aneurysms of the external carotid, jugular vein thrombosis, and post-carotid endarterectomy complications. Now, for the symptoms, it's just a perfect combination of our earlier building blocks. Patients present with unilateral paralysis of the palate, the vocal cords, the sternocleidomastoid, and the trapezius muscles. They also suffer sensory loss, specifically losing taste in the posterior third of the tongue, right alongside anesthesia of the soft palate, larynx, and pharynx.
Next, we step it up a notch in severity to Collet-Sicard syndrome. This is defined by the addition of nerve 12, so you have palsies of cranial nerves 9, 10, 11, and 12. But, and this is super important, it presents entirely without any sympathetic involvement. Now think about it logically. Where must this lesion be? Collet-Sicard is actually far more likely to occur from a lesion completely outside the skull. Why? Well, because if you had an intracranial lesion large enough to hit nerves 9, 10, 11, and snag the neighboring nerve 12, it would almost certainly cause massive, severe brainstem compression. So because this happens extracranially or lower down, the specific etiologies include condylar and Jefferson's fractures, internal carotid dissections, tumors, and remarkably, even systemic issues like Lyme disease and fibromuscular dysplasia. The symptoms? Very straightforward. It is literally everything we just saw in Vernet's syndrome, plus unilateral tongue paralysis from that involvement of nerve 12.
Moving right along to Section 5, Villeret and Tapia syndromes. Let's set up a direct comparison to introduce these next two eponymous conditions.
Let's move to and see how this builds through direct comparison. On one side, we have Collet-Sicard. That's nerves 9, 10, 11, and 12. On the other side, we have Villeret syndrome. As you'll see, Villeret is literally just Collet-Sicard with the addition of sympathetic dysfunction, meaning, on top of everything else, the patient also presents with Horner syndrome.
Because of exactly where the sympathetics join the party, Villeret's goes by a few other unique names. You might hear it called the posterior retropharyngeal syndrome or the nervous syndrome of the posterior retroparotid space. It's usually caused by retropharyngeal lesions. Specific etiologies include parotid tumors, metastases, external carotid aneurysms, and skull base osteomyelitis. And to reiterate, the symptoms just combine the cranial nerve deficits of Collet-Sicard with Horner syndrome, which visually, presents as that droopy eyelid, a constricted pupil, and a lack of sweating on one side of the face.
Okay, now for Tapia syndrome. This is a combined palsy of cranial nerves 10 and 12, which may or may not involve nerve 11. The absolutely crucial diagnostic marker here is that it uniquely spares the soft palate. And here is a fascinating historical fact for you. Tapia syndrome is also known as Matador's disease. It was actually first described by Antonio Garcia Tapia after he observed it in an injured bullfighter. How wild is that?
So what causes Matador's disease today? Well, surprisingly, it's rarely bullfighting. The vast majority of cases prior to 2013 were actually caused by oral intubation trauma. Other causes include metastases and, rarely, carotid or vertebral artery dissections. Symptomatically, because nerves 10 and 12 are hit but the palate is spared, patients present with severe hoarseness and a very specific mechanical dysphagia. Basically, it's caused by incoordination between the tongue and the food bolus. You're also going to see unilateral tongue atrophy, and depending on if nerve 11 got caught in the crossfire, you might see sternocleidomastoid and trapezius paralysis too.
We are on to Section 6, Jackson and Schmidt syndromes. Let's introduce these final two classical combinations to complete our exhaustive review today. First up in our final duo is Hewlings-Jackson syndrome. This was first described way back in 1864. As you'll note, this is a specific cluster palsy of cranial nerves 10, 11, and 12, completely skipping nerve 9. Because we locked in our building blocks earlier, you literally do not need to memorize a new list of symptoms for this. You just add up the isolated dysfunctions of 10, 11, and 12 to get the full clinical picture. Unilateral paralysis of the soft palate, larynx, SCM, trapezius, and tongue. And crucially, because nerve 9 is entirely safe, the patient gets to keep their sense of taste.
And last but definitely not least, we conclude our clinical mapping with Schmidt syndrome. First described in 1892, this is a highly localized palsy of strictly cranial nerves 10 and 11. Because it only hits the vagus nerve and the spinal accessory nerve, it is famously known by its alias, the vagospinal syndrome. Clinically, you are just combining the direct vagus and spinal accessory dysfunctions we mapped out in our master table earlier, meaning unilateral vocal cord, SCM, soft palate, larynx, and trapezius paralysis, completely without any involvement of the tongue or loss of taste. Well, there you have it. We have now covered every bony border, every venous sinus, every single nerve, and every syndrome in this incredibly crowded corridor. But it really leaves us with a fascinating final thought to ponder. With such incredibly tight real estate in the skull base, where literally a fraction of a millimeter changes a diagnosis from Vernet all the way to Cauchet-Sicard, how might advancing microimaging techniques force us to eventually rewrite these rigid historic rules? Anatomy never changes, but how we see it is always evolving. Thanks so much for exploring this explainer with us, and keep questioning what you see.